Hello, InfectoCast folks. Welcome to another episode. This is William speaking, and today we have a special guest who isn't exactly a new guest. He's someone who already participated in the first episodes back in the early days of InfectoCast, back when we used to record in a little room full of mold and used a small recorder, but I have the pleasure of bringing him back here again. Dr. Carlos Kiffer, an infectious disease specialist, a professor, a master, and a friend. Welcome, Kiffer.
Thank you very much, William. It's a pleasure to be here. It's going to be fun. And yes, I participated right from the beginning. We were together in that little room at the hospital recording and some episodes at home, right, that we did about...
Exactly. Pandemic times, we recorded remotely.
During the pandemic, we recorded at home and remotely, but we're in this together.
We brought Dr. Carlos Kiffer here because we're going to talk a little bit about antibiotics, bacteria, and the topic of today's episode, we want to talk a little bit about resistance in gram-positives. When we talk about gram-positives, today we'll end up talking about some specific cocci. These gram-positives are of more interest in infection, and it really ends up being a bit more of a hospital-based context in a way when we consider the clinical implications. But we're basically going to talk about Staphylococcus, pneumococcus, and Enterococcus. Starting with Staphylococcus, when we talk about resistance, it's a historical resistance, right, Professor? Since the time of penicillin and all that. Tell me a little bit about this historical issue of Staphylococcus resistance, which has been building up over time.
Well, it's a long story, isn't it? I usually say that in Fleming's Nobel speech, he was already talking about for us to be moderate in its use. He received the Nobel in 1945, and he was already talking about being careful with the use of penicillins. So he had already recognized that resistance to penicillins was a significant problem even back then. Of course, in that very first generation of penicillins, they were natural penicillins, so Staphylococcus quickly became resistant to these drugs through enzymatic A production. So they developed penicillinases, which were specific elements that could break them down, mobile cytoplasmic ones that spread with a certain speed. That is precisely why Fleming warned in his Nobel speech to be very careful about this. But then came the penicillins in the 50s and 60s, shortly after his Nobel, with semi-synthetic or synthetic ones. Then came the oxacillins and the methicillin, which changed everything. And then this specific problem of penicillinases was finally solved. That is to say, these beta-lactams are designed to resist those enzymes. They are not susceptible to the action of these penicillinases. But another problem started to emerge, which is the problem of gram-positives, which I usually say is the problem of gram-positives in general. It is not just a problem with Staphylococcus, which is the resistance conferred by genetic chromosomal elements, but it is also a process which alters the structure of their protective capsule. So Staphylococcus started to have the bacteria develop a thicker capsule structure acting as a shield alongside modifications to their penicillin-binding proteins that help them resist treatment. And then they started to become resistant to methicillin and oxacillin as well. But in essence, these resistance elements we are talking about, historically they happened at moments. Today, in theory, we don't worry about penicillinases anymore, right? Because we consider that all Staphylococcus have them. We don't use natural penicillin to treat anymore, so we only use the semi-synthetic ones, or we use other drugs when they are resistant to these semi-synthetics. So we don't worry about that anymore. But although this story is changing, that's another chapter, right? We are now starting to see Staphylococcus again that are in fact sensitive to these types of natural penicillins. Look, it's just crazy, but that's what's happening. There are reports out there, reports came out recently, so there is a change happening in this pattern of Staphylococcus, and this seems to be global.
In other words, simplifying it, we don't use penicillin for staph anymore, but staph is starting to become sensitive?
Maybe.
To penicillin, but anyway, I will close this parenthesis now. Perhaps it is a truly rare thing to see. It certainly is.
It is quite rare, and we cannot do that. This restriction doesn't allow us to use it, but it speaks much more to the fact that there is a significant ongoing change in the epidemiological pattern of staphylococcal infections.
Perfect. And when we talk about staph, especially Staph aureus here, in a general sense, we inevitably end up talking about the primary mechanism of resistance, which is what we refer to as oxacillin resistance, or methicillin-resistant bacteria. For medical students, when we are explaining this concept for the very first time, we explain it like this. Look, there is the MRSA staph, or oxa-sensitive, or oxa-S, and then there is the methicillin-resistant staph, or oxa-R, which is the staph that ultimately ends up being resistant to all of my oxacillin equivalents. And so, when we talk about this specific resistance mechanism, I have even seen doctors on duty get back a culture report showing sensitive staph, and they still say, gee, let me just go ahead and prescribe Vanco, because they feel like it is safer or perhaps just better to prescribe Vanco right away, right? It's going to develop resistance, this staph. Let's just do it. And so I wanted you to talk a little bit about that.
No, that's not what happens, right? Let's make it clear that that's not what happens, right? So as I was getting back to the story, right? Penicillinases, natural penicillins, it was, yes, an enzymatic mechanism, and it was, yes, this transmission between isolates that could be from one patient to another. From the moment we developed semi-synthetic penicillins, which are resistant to the action of penicillinases, they started to change their structure. So the change in structure, let's put it this way. The specific change in the binding protein of PBP, along with the thickening of the staph capsule, is actually entirely determined by the chromosome itself. And the staph chromosome is not a transmissible element. It is the essence of the bacterium. So it does not have this horizontal transmission. If a person has an infection caused by an oxa-S staph, they will have an infection caused by a staph. Oxa-S, there is no possibility of that staph becoming resistant throughout the treatment. So now if the person also has a resistance due to a staph, oxa-R, it will be oxa-R from the beginning to the end of the treatment. So there is no point in using medicine. There is no point in using oxacillin here in Brazil or methicillin in the United States. It is useless. So there is no possibility of the oxa-R changing its pattern throughout the course of the treatment. And it is really an illusion to think that vancomycin is better just because it covers both oxa-R and oxa-S. It is not better. There are studies, clinical studies, showing that in staph, oxa-S oxacillin is actually superior to vancomycin or to glycopeptides. So oxacillin is superior when the infection is by an oxa-S. Vancomycin only works when it is for an oxa-R. Then it is not even a question of being superior or not, it is that oxa would not work. So it is obvious that it is superior. So there would be no other alternative. But when you make a comparison that we call head-to-head of Vanco with oxa, for those that are oxa-S, oxa is better in the oxa-S. So it is not better to give Vanco to a patient who has an oxa-S infection. And this resistance is not transmitted horizontally. The person acquires the infection from a pathogen that is oxa-S or that is oxa-R. And then you have to choose the antibiotic based on that.
Perfect. I think the example is a great example of the antibiotic situation, right? For the right situation, that thing we sometimes have, which is it is a mistake to think that, because the fact that an antibiotic has a broader spectrum of coverage means it will be better. Here's the perfect example that if the staph is sensitive, then you have to go with oxa, which will be, it has all that mortality, right?
It does.
I like to use the word mortality because when we are trying to convince someone, sometimes it's more convincing. Look, mortality with Vanco for oxa-sensitive staph is higher. It
is higher.
So we end up not worrying, right? But I wanted you to talk a little bit about this resistance gene, where the main one ends up being MECA, right? And this issue of whether it's mobile or not, this conversation about Staphylococci themselves.
Right. In general, well, what confers the gene that confers this resistance in Staphylococcus is the MECA gene, right? There are others, but this is the main one. It's the most widespread. It's the most common. And the MECA gene, it is inserted into a cassette, which we call a chromosomal cassette. A chromosomal cassette, I usually say, to explain it in a simple way, because otherwise it sounds like very microbiological language, is that it's like a little bag. This little bag carries several pieces of genes, and one of the genes is the MECA, which is inside this chromosomal cassette. This chromosomal cassette is called SCC, so that's why it's the SCC MEC. It is the chromosomal cassette that carries the little bag, which carries the MECA gene, which is the gene that confers resistance to methicillin or oxacillin. As the name itself says, it is chromosomal, so it is on the bacterium's chromosome. So it is transmitted from one Staphylococcus, from an original cell to another daughter cell, to a progenitor cell, to a daughter cell. So I usually say daddy or mommy Staphylococcus. There is no gender distinction in bacteria here, but daddy or mommy Staphylococcus, when they multiply, they will multiply with the genes they have. By themselves, if they pair up, they will multiply with the genes they have. So the little Staphylococcus babies will have those same genes. If they have the SCC MEC that carries one of the types of SCC MEC that carries the MEC-A gene, the offspring will also have it. So this transmission is from one to another. So there is absolutely no possibility of this being transmitted in a non-chromosomal or plasmid way, which could then potentially confer resistance to the bacteria even while the patient is undergoing treatment. That is not what happens. So having said that, what happens with Staphylococci? Staphylococcus aureus in particular are well-known pathogens that frequently colonize the skin and bodies of humans. We have known this for a long time, so diseases caused by Staphylococcus have accompanied humanity. Probably for thousands of years, right?
That was actually going to be my next question. Like, it's an epidemiological question about colonization rates, since you mentioned colonization for thousands of years. So, are we born colonized, or when do we get colonized by MRSA staph?
What do the books say, right? It is likely that this varies from region to region, from city to city, from place to place. But since it is a skin pathogen, look, actually, it is a skin microorganism. It may or may not be pathogenic, right? But it is a skin microorganism. The existing estimates on this, the epidemiology, are that 30% of the human population carries Staphylococcus aureus on their skin. These are the estimates we have.
S. aureus, Staphylococcus aureus.
Regardless of whether it is OXA-S or OXA-R. What gives it the characteristic of being OXA-S or OXA-R, since it is a skin pathogen, is what I usually say. We get the Staphylococcus that we can, not that we want. What we can get is what circulates in our environment, right? So, if an OXA-S staph circulates in our environment, we will catch the staph, catch in quotes, the OXA-S staph. If an OXA-R staph circulates in our environment, we will catch, in quotes, and I am really using quotes here, the OXA-R staph infection. So, where has this traditionally always happened? It has been in the hospital environment. And so, ever since the 1960s, we have been seeing it coming and coming and coming. Observing that within the hospital setting, the patient, what happens in the hospital environment, the patient is confined and the patient shares an environment with a large group, a very high density of people, including other patients and healthcare professionals. They share fomites in the environment such as bed linen, food, and the various items they use to eat. Human contact is much closer if you are confined within a hospital environment. So since the 60s, we have been observing a significant increase, a steady increase in Staphylococcus aureus in hospital transmission, right? It is a persistent challenge that we continue to monitor closely in these high-risk settings because it is primarily a cutaneous pathogen which is transmitted from person to person through direct contact. So it is only natural that we observe significantly more MRSA cases within the hospital environment because in the hospital environment, this has been happening slowly. Since the 60s, we see the first studies back then of MRSA in the hospital environment. It was 10%, 5% occurrence. Today, I would say the average is 50% occurrence.
Is there any Brazilian epidemiological data on the rise of MRSA?
So that is actually a rather curious thing to consider, William, simply because we, historically speaking, know that MRSA, particularly within the hospital environment here in Brazil, has been a persistent issue. For well over 10 or 20 years now, historically, it has consistently remained in the range of 40 to 60% occurrence throughout the hospital environment. So that really means that if a patient, well, let's say instead of just one single patient, 10 patients have a hospital-acquired infection caused by a Staphylococcus aureus bacteria, then 4 to 6 of them, let's just round the math out, 5 of them will be MRSA in the hospital environment and the other 5 will be MSSA, all right? So that is the reasoning. Some studies have recently pointed to this specific environment because then another equation comes into play that I will talk about in a moment. But in this specific environment, it seems there is a reduction in this prevalence. So what was before
40,
60%, we have been seeing in some places the occurrence of what was 50 is now 40, 35%. So what is happening exactly is probably an epidemiological change, as we were saying, a clonal change or something, which we are still investigating, whatever it may be. So there are studies pointing to this around the world. I cannot state this for Brazil yet, but we are close. There are several researchers working on this. We are close to pointing this out in Brazil as well.
Extremely interesting. I honestly don't know if my next question will make much sense to you, but it's a genuinely curious question, and I really wanted to ask if it might make sense at some point for us to talk about staph, vanco-resistant. Is it something that...
Once again, it makes perfect sense because it is always a genuine fear that we in the medical community have, right? It really can happen, right? There are cases reported out there of staph with resistance to vancomycin, a glycopeptide, something that
pops up here, there, right?
But I can confidently tell you that this is still not our main problem here in Brazil, nor is it even in the rest of the world. At this moment, they are still just sporadic cases. Why? It's hard to answer epidemiologically, right? Because in the same way that resistance to oxacillin emerged and these resistance clones started spreading because they are clones, right? Yes. They are very similar clonal groups that transmit from skin to skin. They stay, so it keeps perpetuating itself in the hospital, right? Or in a closed environment. In the same way that resistance, OXA, MRSA emerged and these clones started taking up space, why haven't the few existing resistance clones spread? Vancomycin? I really cannot tell you, right? But yes, it is a potential problem that in theory could happen, okay? However, it is not yet considered a problem of any real relevance in most Brazilian hospitals at this time.
Perfect. I think we've talked a lot about Staphylococcus aureus here. In summary, if the staph is OXA S, give oxacillin.
Exactly.
It won't keep swapping.
The
resistance with another staph. If it's resistant MRSA or OXA-R, you'll give vanco or an equivalent. We've been saying OXA and vanco throughout the entire episode, but their equivalents also apply. Exactly. Otherwise, it gets too long too. But I think that was it for staph. Let's move on to the next chapter, which even in a pediatric context is incredibly relevant. When we talk about a bacterium that is truly significant to medicine in general, we have to discuss the Streptococcus family, which is a major topic we need to cover. And in general, when we talk about Streptococcus, we don't have concerns about resistance. Even when we talk about Streptococcus, it's kind of like, oh, they are universally sensitive. When we refer to penicillins, we are generally talking about beta-lactams, but there are certainly exceptions and important nuances to consider, especially when we talk about pneumococcus, right, doctor?
Exactly. That, by the way, is a major concern I have right now, isn't it? Because Streptococcus pneumonia, right, is actually considered one of the bacteria that most commonly causes community-acquired infections, especially when we look at the data, right? Because who among us, well, let's remember we don't need to go far with COVID, right? Who among us hasn't had COVID?
Exactly.
Who among us hasn't had a bacterial infection afterwards, right? A sinusitis, a bronchitis, a pneumonia, right? Who among us doesn't have nieces, nephews, children, grandchildren, right? In my case, I already have almost a niece and a granddaughter who hasn't had a respiratory infection in childhood, right? Who hasn't taken a beta-lactam in childhood, an amoxicillin clavulinate. Who among us? I have 3 children. They are adults now, but my children must have taken kilos of antibiotics when they were kids.
Kids of an ID doctor, right?
Even more so, children of an infectious disease specialist, right? So they must have taken a few kilos of antibiotics there, right? So and we usually, right, commonly, I am from a generation where we didn't worry about resistance. We're examining the role of penicillins in treating Streptococcus pneumonia infections. It practically didn't exist, right? Then in recent years, we started seeing reports worldwide, the same thing, PBP changes. So remember what we said, the gram-positives, the capsule is thicker. You transmit the bacteria you have, not the one you want. So if you have a pneumococcus with a thicker capsule, with a change in beta-lactam binding protein, that's the one your child will catch. That's the one your little brother will catch. That's the one your colleague or your partner will catch it. So we started seeing reports of a loss of sensitivity to penicillin about 20 to 25 years ago in various places all around the world. And it was really no different here in Brazil. It started happening. First, a reduction since the beginning of the decade of the years, 2000, 2005. Around that time, we were already reporting about 10% reduction in sensitivity to penicillin. Not necessarily a loss of sensitivity, but a reduction in sensitivity to penicillin. We are talking about natural penicillins here, but obviously this also impacted the semi-synthetic ones, right? Amoxicillin, right? Which is the main one used in the community setting. At first, it was a reduction in sensitivity to penicillin, but without affecting amoxicillin, okay?
Correct.
At a later stage, we started to observe a reduction in sensitivity, a resistance to penicillin, and a reduction in sensitivity to amoxicillin.
It lost penicillin, then amoxicillin.
It began to lose effectiveness. The 10% that showed reduced sensitivity to penicillin 25 years ago started becoming resistant and also developed reduced sensitivity to amoxicillin, a semi-synthetic penicillin. And now we have started to see more frequent reports, particularly in the last few years, that have to do with a significant change in the interpretation criteria, simply because there is a debate about the interpretation of antibiograms for pneumococci. In particular, there are different criteria. We adopt the BARCAST criteria here in Brazil. This is very good. It's good to say that
it is a Brazilian database, a database based on what we find in our environment.
BARCAST. And it is a standardized way of interpreting the results with specific criteria adopted by Brazilian specialists, because every exam needs evaluation. Everyone must agree that any exam has an interpretation criterion, because we call creatinine less than 1.2 normal, creatinine greater than 1.2 a deficiency, any glomerular filtration deficiency. Because there is a committee of experts that define that based on population data, So BARCAST is a committee of experts for defining interpretation with local criteria for our antibiogram. And so keep this information in mind. There is a local study coordinated, very well coordinated, by the LACAN of São Paulo, which is the Adolfo Lutz Institute, which is the central laboratory of the state of São Paulo. With the Adolfo Lutz Institute, which is a study called CIREVA, that monitors the evolution of these pneumococci, not just pneumococci. They monitor various things, but today we are talking about pneumococci, and that monitors these invasive pneumococci, isolated from blood and meninges over the years with various isolates that arrive at LACEN. So patients are admitted to public or private hospitals, and these public or private hospitals perform their initial tests there and send the isolate to LACEN, and LACEN tests these isolates. And we started to see about 4 or 5 years ago that LACEN started using the BARCAST criteria, a resistance to penicillin, as I'm saying, around 15-20% resistance to penicillin. But the most dangerous thing about all of this, we are talking about blood isolates, not meninges. A reduction in sensitivity to ceftriaxone, which is and has always been the drug of choice to treat invasive pneumococcal infection. A patient is admitted with community-acquired pneumonia, they receive most of the time ceftriaxone. If they are admitted with meningitis, they receive most of the time ceftriaxone.
That was exactly what I was going to comment on. Every child, adult who is admitted with a suspicion of meningitis, the antibiotic in most guidelines is ceftriaxone.
This is a concern that we have. Why? Because we have only just started to observe this. I am not yet talking about resistance to ceftriaxone in the samples causing pneumonia. It is still a bit early. I'm talking about a reduction in sensitivity. A reduction in sensitivity occurs when the pathogen's inhibition concentration increases to the point where the usual dose we typically use simply doesn't resolve the infection anymore.
Famous intermediate or sensitive increasing exposure.
That's it, exactly. So that is essentially what we are talking about here. We started seeing it in blood samples, which means that if it is present in the blood and also in the lung, right?
Yep.
We started seeing a reduction in sensitivity to ceftriaxone in blood samples. In the blood, we are looking at a range of 5%, 7%, 8%, and maybe even 10% still. Still around 5% and 10%. You might say, 5% or 10% is still a small amount, right? The majority of cases still respond to ceftriaxone. Yes, but we are, in my mind, as a researcher in the field, and even as a father and grandfather, and as someone susceptible to pneumococcal infection, I'm already afraid to use ceftriaxone. If I know that here in the state of São Paulo, at least these samples that we have here, the LACEN report, if it already has a loss of sensitivity in the blood. Now, when you go to the meninges, where the antibiotic penetrates little and where ceftriaxone penetrates less into the meninges than into the blood, these same samples from meninges are already categorized as resistant to ceftriaxone. So in the meninges, these 10% become 15% and not just a loss of sensitivity. We are talking about 15% with loss of sensitivity or resistance. Do you understand? In the meninges. So in the meninges, I think we are already authorized not to just give ceftriaxone anymore. In my view, that's it. So if I have meningitis and I don't know, what is this? Meningitis? It could be Haemophilus, it could be meningococcus, or it could be pneumococcus. At that first moment when the patient arrives,
Is that right?
you don't have the test results yet, so you have to give an antibiotic quickly. I understand the risk of pneumococcus, which causes a third of meningitis cases today. If a third of cases are pneumococcal and nearly 20% show reduced sensitivity, will ceftriaxone still penetrate effectively? I wouldn't want to receive ceftriaxone if it were me, so I would prefer to be given ceftriaxone plus something else because ceftriaxone works for meningococcus and Haemophilus, but for pneumococcus, it is losing its effectiveness. So in that sense, in public hospitals, here at Hospital São Paulo, for meningitis, we have been recommending ceftriaxone and vancomycin, which is the drug of choice we have. Regarding patients with pneumonia, those who do not have meningitis, as it is a completely different disease, every clinician and infectious disease specialist knows these are two distinct conditions. But we are already seeing patients who are poor responders to ceftriaxone, okay? I already have clinical reports of this. We have already discussed clinical cases of poor responders to ceftriaxone. It is
a concern that we must have, especially since these are serious infections, right? Pneumonia and especially meningitis, which are infections where at the first moment you don't want to get your antibiotic choice wrong.
That is correct.
Later we can try to edit and put it in the video, but I always like to discuss the pneumococcus antibiogram because it can come now, as you mentioned, right? It comes there, penicillin can come resistant, you can have a ceftriaxone, and sometimes in the antibiograms they even separate it, right? The MIC for meningeal, it is the meningeal.
Exactly, because of this interpretation criterion. Because since I reach higher concentrations of ceftriaxone in the blood, you give it directly into the blood and you reach higher concentrations. You allow for an interpretation with higher MICs to call that sensitive. But that same concentration is not reached in the cerebrospinal fluid. So you have to set the interpretation cutoff line lower. That's why the difference. It doesn't mean that the pneumococcus is essentially different from what is causing meningitis and what is causing the pneumococcus as a bacterium. It is not essentially different. The
same is in the head and in the blood.
Exactly. What changes is the interpretation criterion for where your antibiotic reaches or not. So if I'm already seeing a loss of sensitivity for meninges, it means that I also have some reduction in the action of this antibiotic in the blood. If I don't give the right dose, what is the right dose? So if I'm saying that around 10% of the pneumococci in the blood are associated with pneumonia, right? That's what we think. If it was isolated in the blood, the person has pneumonia. Sensitivity to ceftriaxone is already reduced, meaning I must give 2 grams every 12 hours instead of the standard 1. Usually, we treat with 1 gram every 12 hours. So who are these poor responders? They are the ones we end up seeing. 48 to 72 hours after starting ceftriaxone, 1 gram every 12 hours, the patient is still febrile. He remains tachycardic with persistent leukocytosis and elevated CRP. He's not responding quickly. You gave 1 gram every 12 hours, but the culture showed sensitivity requiring higher exposure. You didn't give the right dose.
I think we can add it later, right? I have the antibiogram results for this infection, which came from a blood culture, and it confirms the presence of pneumococcus, which is right there. Ceftriaxone intermediate. When it's non-meningeal and meningeal, it's already resistant.
Resistant?
Exactly. I always like to highlight these cases, especially for the residents and everyone else, so they understand. Regarding the pneumococcus profile, excluding pneumococcus, are we still okay with the other streptococci?
Still okay, but that is changing. So the message is that it is changing. For meningitis, I think I can speak for the state of São Paulo. I can't speak for other states because I don't have the knowledge.
Right, in
the state of São Paulo, with data from Adolfo Lutz, I can say for meningitis in public settings, start ceftriaxone and vancomycin immediately. It is debatable if increasing ceftriaxone for pneumonia in hospitalized patients is worthwhile. Instead of 1 gram every 12 hours, use 2 because it's hitting around 10%, right? That tolerance threshold that we infectious disease specialists have to talk about if it works for 90%. Okay? I'm not sure if I really like this tolerance threshold. I think that's a bit complicated. But historically, we as a specialty have adopted this.
Often in pediatrics or for the immunosuppressed. Maybe
Thinking of a higher dose.
thinking about a higher dose. Perfect. We've just discussed a little bit about pneumococcus, right? This profile has been a bit more concerning. Let's move on now to the last part to talk about our situation here in Brazil, where it's a smaller problem, Enterococcus, right? I think it's a problem we see more in North American literature, if I'm not mistaken. And when we talk about Enterococcus, we end up talking basically about two species, Enterococcus faecium and phaeacalis. They already carry a certain level of importance for endocarditis, urinary tract infections, and bloodstream infections. Outside of this context, they generally aren't as relevant, right? But I wanted you to talk a little bit about, well, the two of them. They already carry some resistance in a general way, right? The difference between one and the other.
What is concerning about Enterococci for us, right? It's the resistance to glycopeptides, right? Let's say those are the genes, right? VAN-A and VAN-B mainly. There are others, right? C, D, E. But the main ones that cause resistance to glycopeptides, resistance to Vanco, right? Or TACO. The
famous VRE,
right? These are the most concerning, right? I would say that the Enterococci that cause community-acquired infection, for the most part, how do I think about this, right? How do I, as a specialist, think about this? And here it's not the professor, it's not the academic, it's the doctor who also takes care of patients every single day. I would say that if a person without hospital risk factors coming from the community with a possible Enterococcus infection, what situation is that? Endocarditis, right? Community-acquired and spontaneous peritonitis. It will probably be Enterococcus faecalis, right? Enterococcus faecalis here in Brazil, I always say that when we talk about epidemiology, we get it right wholesale and get it wrong retail, right? So I'll get it right wholesale. It might be that I'm getting it wrong retail in some Brazilian region, right? So wholesale, I would say that less than 10% of our faecalis are resistant to glycopeptides, are resistant to Vanco.
90% of Enterococcus faecalis are generally sensitive to ampicillin.
And they are sensitive to Vanco too. They are sensitive to ampicillin, sensitive to Vanco. So it's not a big problem when you are within that little box of classic community-acquired infections. Now you have another little box, hospital-acquired infections. As for hospital-acquired infections, what happens in most Enterococcus infections in a hospital setting? These are those patients who have been hospitalized for a long time. These are those patients who have already used antibiotics widely, particularly antibiotics that select for gastrointestinal tract pathogens. What am I saying? You gave this guy beta-lactam and it killed his Enterococcus faecalis. So which Enterococcus was left in his intestine? It was the faecium. And this faecium already here in Brazil, I would say the balance inverts. You
killed the good brother and left the bad brother.
The balance will invert. And so the faecium, they are, and I will probably get the wholesale wrong. In retail again, about 80 to 90% are already resistant. So glycopeptide is understood, and then those are the specific ones we'll be looking at, right? So most of the time there, but that's already another problem, meaning it doesn't, vancomycin won't work. You have to go to another drug, linezolid. Maybe then you have to choose another drug that works for these hospital environments. Of course, you say, see, and as a cause of infection in a hospital environment, it's not the most frequent. There are many other gram-positives that are more frequent in a hospital environment, but once again, getting it right in the big picture but missing the details, it is possible that there are private hospitals in private settings. I'm not talking about private hospitals, but hospitals in certain environments that may have more or less prevalence of this VRE. But in epidemiological logic, VRE is probably, when you become a VRE, it will be an E. faecium. Sometimes it can be a faecalis. Less than 10% of the time it can be a faecalis in a hospital environment, which is resistant to VRE, but it is not the common case. Faecalis tends to still be... So I make this distinction because it helps me think. It helps me think. In the community, I understand that I should see a faecalis, and it should be sensitive to ampicillin, it should be sensitive to vancomycin, it should be sensitive in the hospital environment. Why? have a problem with Enterococci, it will probably be E. faecium. So it will be the patient who has been hospitalized for a long time. It will be the patient who has eliminated the natural microbiome of the gastrointestinal tract, leaving only faecium. And then when the person has a translocation or gets an infection, they get from VRE, from faecium, right?
Perfect. When we talk about oxacillin and vancomycin for staph or Enterococcus, it's the same principle. If I have an ampicillin susceptible Enterococcus, ampicillin is a better option than vancomycin, right?
Yes. Traditionally for Faecalis, we know very well that we already have many clinical studies showing that ampicillin works. It is a very good option.
And now with right? You mentioned mainly the hospital environment, the phase, the VRE. Thank God I, for example, don't usually see it. I think I had one infection in the last 6 months. And it's a problem because when we talk about Vanco, it's a cheap antibiotic. And for many public hospitals, SUS, after you've lost Vanco, what's left is linezolid, which is more expensive. Daptomycin, which is more expensive. That's something I was going to ask. Is it possible eventually for teicoplanin to be an option for VRE?
It is depending on the resistance gene. So this is something I suggest to colleagues who might be working in a clinical environment where VRE is a significant infection control problem.
Exactly.
That it will exist. VRE in colonization, there's no doubt. But how many of these colonizations will effectively turn into an infection? It's just that the colleague needs to be attentive. Because if VRE is a problem in their environment, I would suggest that they talk to the laboratory and ask the laboratory to identify which VRE this is. So if it is indeed E. faecium, it should be epidemiologically speaking, right? I am speaking here based on epidemiological data. And if it is to be tested differently, Vanco and Teico, because the susceptibility might be different. Depending on the gene it carries, it may maintain susceptibility to Teico and resistance to Vanco, okay? Regarding Vanco, it depends on the gene. I can't say for sure, as we lack epidemiological data on whether it's mostly Van A or Van B. It really depends on the local environment, so it would be interesting for them to explore and see what they have. Maybe they don't have it, so they skip Vanco and give Teico instead. Or perhaps neither is given and they have to move on to a more expensive drug, just as you said.
Perfect. I think we've covered everything about the 3 ugly little gram-positive bugs. I think those are the main ones. When we talk about gram-positive, especially in a hospital setting or severe infection, which we end up admitting, once again, thank you very much. It's
a pleasure. Always good to be here to chat. We refresh and think in a different way.
Exactly. So that's it, everyone. Thank you very much for your audience. If you're not following us on our Instagram page yet, follow us there. Please turn on notifications in your podcast aggregator to receive alerts for our episodes, which are released weekly. We have been posting new episodes quite regularly every Friday. Follow us on YouTube as well, where we always post new content on a regular basis. And InfectoCast, we tell you what no one else tells you. See ya!